Okay, thank you very much. Thank you for the introduction and thank you for the invitation. So, I will speak about epidemiology, an overview of HIV epidemiology, and I'll focus on HIV treatment, especially for intravenous drug users, oral and injectables, what we have in HIV pipeline, and HIV prevention. So, what about HIV epidemiology? As you may see here, I will start with a vision and a dream, as George says. End AIDS as a public health threat by 2030. This is a call, and as UNAIDS report talk, is the HIV response is at a crossroads. HIV treatment is reaching more people than ever before, but almost 30 million people were receiving antiretroviral therapy in 2023, among 39 million people that live with HIV. A public health success that has reduced the numbers, as you may see from the graph, to the lowest level since 2004. And the global response has moved closer to the goal of ending AIDS as a public threat by 2030. Enhanced access to HIV treatment is having a dramatic impact in AIDS mortality. So, if you see from the graph, the rates of declining the HIV incidence and the AIDS-related mortality is not sufficient, is insufficient in order to achieve the targets of 2025. And why this happens? Because 55% of the population among new infection, HIV infection, concerns people, key population. And who are they? As you may see, there are people who inject drugs, men who have sex with men, transgender women, sex workers, sex partners of people from key population, and clients of sex workers. Many HIV programs neglect this key population, and if we do not address all this population, the epidemic will not finish. And the first step is late diagnosis, is to diagnose these people. As you may see, injecting drug users are coming in our care late. More than 50% of HIV diagnoses have CD4 count less than 350, and more than 30% of cases, they coming with advanced HIV disease. And what about the continuum of care? Among 8 countries reporting all the stages of the continuum for people who inject drugs, only 52% people who inject drugs living with HIV were virally suppressed, compared with 70% among all people living with HIV. This gap highlights the need for tailored approach that includes harm reduction and innovative methods to improve outcome to this key population. So it is vital to initiate treatment very soon, ideally within less than a month after receiving the positive diagnosis. More than 20% of people who inject drugs start medication, start antiretroviral treatment in more than 2 months. So the strategy to start medication in the first visit is coming recent years because the drugs are safe and very tolerable. And this strategy addressed the option that controlling the epidemic and optimize health for these people is better for them to start medication at the first visit. So what about treatment? We have, until now, oral treatment and injectables. You may see the evolution of an antiretrovirus treatment from 1996 with highly active antiretroviral therapy with a combination of 3 drugs, until today, And you may see that the evolution of these drugs are going to a safer, less toxic medication, and especially the two last drugs, cabotegravir, which is the new integrase inhibitor, which is injectable and long-acting, and lenacapavir, which is a new capsid inhibitor, which is also oral but also injectable, goes for addressing the burden of everyday pill to all these people who are having this chronic illness. ART is recommended irrespective of CD4 count, and antiretroviral drugs provide a combination of essential characteristics for an optimal treatment, which has this characteristic: long-term efficacy, higher barrier to resistance, safety, tolerability, and few drug-drug interactions. And we need to start, as I have already said, early enough, even at the first visit. So for rapid initiation of ART, we need triple therapy. We do not give two drugs because we do not have a genotype-resistant test result. And especially for drug users, we do not give any pharmacoenhancer in the combination of HIV treatment due to drug-drug interactions. Here is a prospective, single-arm, open-label study. You may see from this study aimed to evaluate the BF-TAF, bictegravir FTC-TAF initiation, rapid initiation in the first visit with peer navigation support for people who inject drugs. These people were treatment naive or treatment experienced but relinking to care. You may see that 89–90% were employed, 11% were experienced transient housing, and the median time from diagnosis to ART initiation was 0 days for this population, the study participants, compared to 141 days historical controls from the same HIV units. So you may see we can change our care and our kind of care in order to succeed viral suppression and retainment to care. At week 44, 91% among study participants have a viral load less than 40 copies per ml, compared to 40% in historical data. There were no treatment-related adverse events, and this study says that rapid BF-TAF initiation combined with peer navigation support was effective in achieving high rates of rapid viral suppression among people who inject drugs compared with standard practice. So the first thing is to diagnose and rapid initiation. The second is to adhere. In order to adherence is very important for this kind of people, for all people living with HIV, because only with adherence during the years we can succeed viral suppression. And durable viral suppression prevents emergence of resistance, improves outcomes, and prevents transmission to others. You may see from this study reported in ID Week 2004 that tried to compare two kinds of therapy. The one is BF-TAF and the other is dolutegravir plus 2 nukes, and try to see if there is a difference between the proportion of viral suppression concerning the adherence. You may see that in the category of lower adherence, BF-TAF was better regarding it is an STR regimen, so it's better for people like drug users to have an easy to take drug. So no participants in this study had treatment-emergent resistance, and 2 participants on dolutegravir plus 2 NUCs have HIV RNA detectable, and both are emergent resistant. What about injectables? Injectables, as I told you, have the capacity to give them every 2 months or every 6 months in order to be more convenient for our people. So this study was a study among adolescents. We know that adolescents with HIV infection struggle to adhere to HIV medication, and less than 10% have viral suppression. So this study in cohort 2, the study participants were adolescents, virologically suppressed, who switched to an oral cabotegravir plus rilpivirine for 1 week, for 1 month, and then every 2 months, intramuscularly, they were given the long-acting combination of cabotegravir plus rilpivirine. The primary outcome was safety, and the secondary outcome was pharmacokinetics. So in this study, no cases of virological failures occurred through week 48, and all 140 participants who responded to this questionnaire preferred long-acting injections. We have to keep in mind that long-acting injection, the patient has to come in our unit in order to take the injection. So in order to keep the patient retained to care, we need support from NGOs or family members in order not to stop the medication. And what about pipeline? I'll show you only some studies regarding phase 2 studies. The one study is oral bictegravir plus lenacapavir in people with virologically suppressed HIV on complex ART. You may see here that adults who were on a complex ART regimen randomized to take bictegravir plus lenacapavir in 2 different doses or continue with the ART regimen. And at week 48, all the participants in the arm of bictegravir lenacapavir 50 mg QD were virally suppressed. So bictegravir lenacapavir STR will be assessed in a phase 3 study, option study for simplification. And what about prevention? So very few countries are on track to reach the 2025 harm reduction rates concerning sterile injecting equipment at use or opioid substitution therapy coverage or overdose coverage. And also, harm reduction services include PrEP. You may see that PrEP is very, even people who inject drugs express high willingness to use PrEP. They actually have low uptake of it. You may see here a single-arm open-label trial about the persistence in post-prescription PrEP. And you may see from the graph that participants were prescribed PrEP for 90 days, and only 60 people among 100 people picked up PrEP at least once. So oral persistence in people who inject drugs for PrEP was low, and programs focused on PrEP in people who inject drugs may help to support persistence. This long-acting drug, lenacapavir, given every 6 months, was reported in June 2024 with the study of Purpose 1 in South Africa and Uganda. It was closed early due to the finding of an extremely high efficacy of lenacapavir. None of the more than 2,100 adolescent girls and young women who received the twice yearly injections acquired HIV. So in this study, HIV-negative women, cisgender women, HIV-negative and not on PrEP, they were randomized to receive either lenacapavir subcutaneously every 6 months, or FTC-TAF, or FTC-TDF, oral daily. All the participants also took placebo, either subcutaneously injection or oral placebo. And the outcome was the HIV incidence among these three parts. The background incidence is the incidence without PrEP that would have been expected in this population in a placebo group. So you may see that no incident HIV acquisition were observed in the lenacapavir group, which is amazing, and HIV incidence on FTC-TAF was not different from background HIV incidence. And you may see here from adherence, on time adherence to injection was high. Most participants in both oral groups overall had low adherence to oral tablets, and adherence declined over time, as you may see from the red bars. So this novel study creates a path forward for future PrEP options, as there were zero HIV infection in cisgender women receiving twice yearly lenacapavir for HIV prevention. And in September 2024, twice yearly lenacapavir for HIV prevention reduced HIV infection by 96% and demonstrated superiority to daily PrEP with TDF-FTC. This study, Purpose 2, was among cisgender men and gender-diverse people. And so this study adds evidence to of using lenacapavir for HIV prevention. So for key takeaways, epidemiology response is at a crossroads. The inequalities, and especially the key populations that drive the HIV epidemic, must be addressed. Rapid ART initiation combined with peer navigation, especially for this key population of people who inject drugs, is effective in achieving high rates of viral suppression. Long-acting cabotegravir plus lipivirine is the first long-acting combination which demonstrates favorable safety and PK profile. But without the support of harm reduction services, this treatment strategy could be a challenge regarding adherence. And for prevention, powerful prevention technologies such as long-acting cabotegravir and most recently lenacapavir are raising expectations due to the combination of convenience and high efficacy. If this PrEP option is made available rapidly and affordably to potential users, it could herald a breakthrough for HIV prevention. Thank you.